Good morning, everyone. This is Jennifer Geisert with CIMRA of Nebraska, and I want to welcome you to our event today. Our WebEx is given by ENOA, Eastern Nebraska Office on Aging, and the title is Emerging Market of Participant-Driven Long-Term Care Services and Supports. I'm going to go through just a few items to take care of before we start the program. If you have registered and want CE, that will be taken care of, and we'll be sending the CE certificates out. If you are on the line and have not registered and want CE, you need to go to the invite and actually register so that we'll be able to give you the CE credits for today. As part of that, also, we'd like you to fill out the survey that will come online to you after the WebEx. That helps us to know how the presentation went and what kinds of things we can improve on. So we really appreciate you taking that few minutes to fill that survey out. It's very short, only I think roughly 4 questions. So very, very easy. If you'll do that, we will be sending that out after the presentation today. The sign-in sheets should have come to you with the handouts, and that will need to be turned back into me as also part of that CE requirement. So if you could fill those out and either email them or fax them to me, the information is located at the bottom of the sign-in sheet for that. So I will introduce our presenters today. We have Janelle Cox. She is a social worker, and Heather Iverson is an RN. They both work for ENOA. Janelle has over 25 years of work experience in human services with 15 years focusing on the aging population. She currently oversees the Choices program, which includes care management, caregiver support, management, aid and disability or disabled Medicaid waiver in the Senior Care Options program, as well as she works with the Community Care Transitions program. She also is active with the Department of Health and Human Services in their Waiver Quality Assurance Council, and has served on the CQI committees and the MDS 3.0 Section 2 electronic referral process. That is a mouthful. Heather is, as I mentioned, an RN. She has also completed other coursework in biotechnology from UNO. She began a career in long-term care and has worked in various long-term care facilities. She also has experience in the hospital setting. She worked at St. Francis Medical Center and also in the burn unit at Clarkson. She has a wealth of information to share with us today, and knowing that she has some background in case management, that will, it looks like 10 years that she has been involved with assisting seniors in care management. So I know she's going to be giving us some examples or like case studies at the end of the program today, and so make sure you're staying on the line to hear that. At this point in time, I am going to mute the lines, and Janelle, I'll remind you, after I get done muting, you will need to press *6 to unmute yourself. We also have the chat function. Anyone, if you're wanting to use that, please feel free. And right now, I'll go ahead and mute all the lines.
All guests have been muted. You can unmute your line by pressing *6.
Okay, Janelle, you can go ahead.
Okay, thank you, Jennifer. I'd like to thank Jennifer for all of her work she's done today for setting up this presentation and for being patient, as Heather and I were both a little under the weather last week. So the title of our presentation today is The Emerging Market of Participant-Driven Long-Term Care Services and Supports. As many of you I'm sure we're clearly aware of, we used to hear a lot of information about preparation for the baby boomers as they age. And as we kind of have been watching what's been happening in the aging arena as well as the healthcare arena, we've seen some significant changes taking place that I don't think that we really haven't looked at them in depth, and this is part of what this presentation hopefully will accomplish today, is to kind of look at really what is going on with the healthcare arena and in that human services component, because, from the aging side of things, we're being told, we're going to do more services with no increased funding, and on the healthcare side, what we see the big theme is that we want you to continue to also do quality service but become more cost efficient. So when we look at currently what's happening with the aging population, in 2013, more than 2.5 million passed the milestone of turning 65, and by 2030, the over 65 crowd will expand to 72 million. That's going to be up from 40 million in 2010. With these exploding numbers, it means that there's going to be an ongoing strain on the insufficient government resources with no increased funding, which is going to include both Medicare and Medicaid, affecting both private healthcare industry and the public human services agencies as well. And I thought that this was a very interesting fact. When all was said and done, some 78 million baby boomers will have survived millions of hip replacements and heart transplants, and all will be insisting on the comforts of home regardless of the treatment setting that they're in. When we continue to look at aging and health, we are also seeing a shift occurring, and that shift comes in the leading cause of death that's switching from infectious diseases and acute illnesses, and it is going towards the chronic disease and degenerative illnesses, where there we see some of the shift that currently comes from the efforts that we're putting in the chronic disease management education for patients. 2 out of 3 older Americans currently have multiple chronic conditions, and treatment for this population accounts for about 66% of the country's healthcare budget. One of the keys to improving health and the quality of life for all older adults was recently stated in the State of Aging and Health in America in 2013, would be that collaborative effort between multiple and diverse groups, and really looking at a joining between public healthcare providers, government agencies, and community organizations. This is where we kind of see the beginning of the emerging market as we are looking at it, because on the aging side, what we're hearing at the national level, filtering down to us, is that area agencies on aging need to be looking at adopting more of a business type model. So we're looking at our line of work expanding more to align with the healthcare premise. And so we look at the growing number of the aging population. If you add into that the increased number of those diagnosed with chronic illnesses, really what this is kind of forcing at this point is required interventions to reduce costs and limit risk, because chronic illnesses, of course, are very costly. Effective and efficient interventions can be achieved with what is believed to be an integrated healthcare system, by blending the integrated healthcare system with home and community-based services. Working with older adults to achieve their definition of quality of life, quality of care, and quality of life may not be what I classify as quantifiable. And as I sat in different workshops on the national level, I think that's one of the challenges that we continue to see, where we're trying to blend the human service agency side with the medical model side, in that some of those quality measures coming from a human service agency perspective are more qualitative than quantitative. So this kind of shows what we here at ENOA have been watching, and on the medical side of things, we're seeing such things as the partnerships for patients, the accountable healthcare organizations. As they have developed on the human service side, we're also seeing the expectation of increasing home and community-based services, funding going to Money Follows the Persons, which is transitioning folks out of those long-term care systems. And we're also seeing an increased emphasis on caregiver support programs, because I think more recognition is coming to that informal caregiver and being able to preserve them in providing care for our aging population as a more cost-effective means. Out of that, we're seeing some of these, what I classify as emerging markets, being the patient-centered medical homes, where we see care coordinators in the clinic setting, managed Medicaid long-term care services and supports, where we see managed care companies collaborating with the human service agencies to do some capitated risk services, and then also the community-based care transitions program. When we look at the community-based care transitions program, this is one of the programs that has focused on that person-driven services and supports. And in community-based services, the delivery model that we emphasize is around the person-driven services and supports premise, because it empowers that older person or person with disability to be able to have the opportunity to decide where they're going to live or with whom, and to have control over the services that they receive and who provides those services. It also allows us then to include those cost-effective means of having informal friends or family supports, and who helps them participate in community life. We also allows the person to ask questions to help them make informed decisions, and it promotes self-directed care and accountability. This model can also provide significant insight, I believe, into the reason why one patient may be successful over another with a similar known medical history, taking into consideration if they are more engaged in their healthcare decisions, more accountable with, say, such as their self-management of medications. We have seen significant information that leads us to believe that that has a significant impact, especially in community care transitions, in reducing the readmission rate. To achieve a successful person-driven approach to services and supports, the following really needs to occur, and we need to be able to shift that authority from the provider who has been dictating what is needed or what will happen, and shift that authority back to the person. This will allow decision-making and problem-solving to be shared. I know even in our work here in care management, at times it's much easier to tell a participant, due to our background and experience, this is what you need to do. But unfortunately, we've seen more success if we truly engage them and kind of lead them to that conclusion, asking for their input as well. Encouraging the person to be involved in his or her care and becoming an active participant in strategic decision-making and planning. One of the particular issues at times that we see is looking down the road, say perhaps for long-term care needs, and even if we're looking at long-term care placement, we like to take the approach and encourage our participants here in our different programs at ENOA that if you need to be prepared, don't wait until you're not feeling well to try and make decisions about where or who you'd like to receive services from if the need happens that you need that long-term care placement or even a rehab placement per se. So in the emerging market, the Community Care Transitions Program is successfully utilizing the person-driven model. The CCTP primarily focuses on coaching, which I think has really been of value to this program. Thus, this shifts the authority and gives permission to the patient to become more engaged in his or her health care. Just to give you a little history about where ENOA is with their CCTP services. In January 2012, ENOA was approached by Untitled Healthcare Network to partner with them in delivering community care transition services to qualified Medicare beneficiaries discharging from Allegiant hospitals in the Omaha metro area. ENOA's CCTP services officially began in July of 2012, and we used the Coleman model to deliver in-home care transition services. ENOA places specific emphasis on coaching techniques to empower participants to take on more responsibility and to truly become an advocate for their own health care needs. Our CCTP coordinator also utilizes the teach-back method to ensure participants understand pertinent information. I think currently at this time we're still working with an aging population who is somewhat intimidated to ask a health care provider during a follow-up visit to slow down, to be able to ask questions. And so with our CCTP services, we really do get into looking at what questions do you want to ask, what information do you need, and how can you go about asking your healthcare provider for this information. The CCTP services through ENOA currently include an in-home visit. We demonstrate medication self-management through doing medication reconciliation from pre to post-discharge from the hospital. We also are introducing and providing education on using the patient-centered healthcare record that can help guide patients through their care process. We use this as something that they can carry with them. We explain to them how they may use it, ask them questions on how they may feel it may be used, and then sometimes we'll even start off the personal health record for them and then kind of help determine how they foresee that might be used in the future, say if they carry it with them, and then if they would have a healthcare provider or nurse at the clinic actually update that record for them. Exploring the patient's understanding of red flag indicators of worsening conditions and the next appropriate step. We always like to get a baseline initially and have the patient tell the CCTP coordinator what their understanding of potential risks or worsening symptoms might be, instead of just assuming that they have no knowledge, just to kind of see where they're at. Discuss follow-up appointments and try and identify if there's any barriers to making those appointments occur, whether it be transportation, perhaps the discharge instructions said that the patient was supposed to call and schedule the follow-up appointment, so we make sure that they've done that. And then exploring, again, as I said before, the strategies to ensure that all their questions and concerns are addressed during those follow-up visits. After that's complete during that home visit, then we also discuss with the participant how they would like to see follow-up contacts occur and try and make those contacts according to their preferences. Primarily it's done usually, most often, via the telephone. We've had occasions, though, and it's nice to have that type of flexibility where a second visit may be required to go out into the home. The lessons that we have learned at this point, initially when we started our services, we were utilizing existing staff. We did learn that we really needed to have dedicated staff specifically for CCTP services. So in August of this year, Heather Iverson, who had been working in our care management program, as well as doing some of the CCTP services, then became fully dedicated as a full-time staff member to CCTP. We have our next full-time staff member starting in about 2 weeks from now. We've really learned, and as you'll see through Heather's examples, there's nothing as valuable as eyes and ears in that home setting. I think there really is pieces that could be missed, and you would have no clue about that unless somebody was actually out there visiting that client in their home. The other thing, and it's been kind of a nationwide dilemma, is how do you get the patients to agree to home visits? We've tried lots of different things, and really I think one of the key indicators that we're seeing is if we can get that home visit in to occur as close to discharge as possible, we have a higher success rate with that. Once a patient has been home for a few days, perhaps they're feeling better, they don't think that the home visit is necessary, there may be things that they don't want to, or maybe they're not feeling well, and so things are a little disorganized in the home, so they don't want anybody that they don't know out visiting them. However, if we can get them closer to discharge, it seems like their level to resist is a little bit decreased at that point in time because they really want to ensure that they're able to continue to stay at home. Many older adults need to know it's okay to ask their healthcare provider questions and to be able to tell that healthcare provider when they don't understand the answers. And I think that's one of the things that Heather also focuses on is because a lot of times a healthcare provider may think that they've given a fantastic answer and that patient has no clue what they have been told. And so when we're looking at utilizing some of that teach-back method, that's also something that would be helpful on the healthcare provider's portion too as well, is to kind of adopt that, especially with older patients, to say, what's your understanding of what I just said? With that, I'm going to turn it over to Heather now, and she's going to discuss a few of our case examples.
Thank you, Janelle. I have 3 patient examples that I would like to share with everyone today. My first example is of a 64-year-old male that had been admitted to the hospital with right-sided facial numbness. During the home visit and upon reviewing the discharge instructions, the following was discovered. The patient had not notified his primary care physician or neurologist to schedule follow-up appointments. The patient hadn't filled his new prescription for the steroid that was ordered, and the patient was instructed to hold a specific blood pressure medication if he didn't recognize this. So during the home visit, medical appointments were scheduled and assistance was provided at his request to arrange transportation. We discussed various medication management techniques, and the patient decided to begin to use a Mediset. Medication reconciliation was achieved, and the patient was coached on how to fill the MediSet. The following week, the patient was notified, and he had confidently informed me that he had filled his MediSet for the following week. As an afterthought, the patient requested that I make a follow-up home visit to double-check his MediSet. Upon reviewing the MediSet, the following was discovered. The patient had placed a sleeping pill in the AM in addition to the PM slots. The once-daily antidepressant was placed in the morning slot and in the PM slot. An old dose of an antipsychotic medication was placed in with his new dose. And the patient had added the blood pressure medication that was to be placed on hold. At this time, we discussed alternative medication management options, and the patient decided that bubble packs would be more ideal, so his medications were set up by a local pharmacy. The patient also agreed to bring his medications in to his primary care physician's office, who also had a on-staff pharmacist, in addition to pharmacy students, who could perform a medication review when he had medication changes. The nurse for his primary care physician was notified and updated, and the nurse for the neurology clinic was also notified and kept in the loop to safeguard against future medication errors with future medication changes. My second example is of a 70-year-old male who had been admitted to the hospital for a heart attack and stent placement. I had received this referral because the discharge transition nurse from the hospital had placed a post-discharge call to the patient and spent well over 20 minutes reviewing his medications and felt that the patient didn't have a good understanding of what he was to be taking. I had great difficulty getting an appointment scheduled because every time I would call, the patient's wife would answer the phone, and she strongly felt that the patient understood his medications and that there weren't any problems. Once I was able to speak to the patient, he had told me that he was managing his medications just fine, but when I asked him if he had stopped 3 of his medications that he was supposed to, he said he had, but couldn't remember the names of the medications. The patient then informed me that pharmacy wasn't getting the correct medications to him. With that, the patient agreed for me to contact his primary care physician's office, and I spoke with the nurse who was instrumental in getting a home visit scheduled. During the home visit, it was discovered that the patient nor his wife could locate the discharge instructions. We reviewed my discharge paperwork, and the following was discovered. The patient was without the newly prescribed cardiac medication. The patient didn't realize that he was to stop taking 2 of the previously prescribed cardiac medications and 1 diabetic medication. And overall, the patient wasn't taking any of his medications. In addition to these findings, the patient was fully ambulatory in the hospital setting, but since he had been without his anti-gout medication, he was unable to bear weight on his right foot. After much convincing, they both agreed to have their daughter manage the patient's medications. Their daughter was notified, and she came right over and set up the patient's medications. She also made sure that the patient had his newly prescribed cardiac medication. The patient's primary care physician was also notified, and his post-hospitalization appointment was for the following day versus the following week. And in addition to that, home-delivered meals were also put into place for the patient. My third and final example is of a 71-year-old female whom I had met with in the hospital prior to discharge. She arrived to the emergency room in respiratory failure and was immediately intubated. She was admitted to the intensive care unit and discharged from the intensive care unit directly to home. Her new prescriptions included an antibiotic, steroid, and an inhaler. The patient went home on Monday and agreed to a home visit on Wednesday because she had many things to do before my arrival. The patient hadn't yet filled her steroid or antibiotic. Education was performed at that time regarding medications and how they related to the disease process, and encouragement was given to get them filled. I had called her the next day to find that she still hadn't filled them because she didn't have any money, even though the antibiotic and steroid cost under $10 total. I offered to use a Target Pharmacy gift card from ENOA to pay for her medications, and she became very short with me and informed me that she would just borrow the money from a neighbor. I notified her the next day, and the patient had obtained those 2 medications and successfully completed their course. The inhaler that was prescribed was very expensive. With the assistance of the Unmet pharmacist and the nurse ambulatory care coordinator with her primary care physician, I was able to determine the appropriate course of action in regards to ensuring that she would be able to continue to receive her inhaler. Of note, this patient had been hospitalized several months back and was never seen in the primary care physician's office nor by pulmonary. The patient was encouraged to follow up with her doctor's appointment, and she did notify both her primary care physician and her pulmonologist. Transportation was an issue, and through ENOA funding, she was able to get to both appointments. This was a huge success because she had never had pulmonary function tests before, and these were completed. A referral was also placed to the Unmet social worker for her to assist the patient with the completion of the MOBI application so that a long-term solution would be put into place. And finally, to ensure that the patient would have adequate disease management support, a referral was placed to the Unmet disease management nurse. This patient had been hospitalized in August, and to my knowledge, she hasn't been hospitalized since. I was pleased to hear from her in December when I had received a Christmas card from her thanking me for the time and the effort that I had spent with her. And on that note, I will go ahead and return the time back to Janelle.
Especially with the last example that Heather has provided us, I think that truly kind of brings us back to what we have wanted to accomplish with this part of this presentation, that emerging market, because the emerging market is really creating an environment that has continuity between the healthcare provider and the social service or human service agencies such as ENOA. We utilized a lot in that case. We used some resources from ENOA. Of course, as we are a contracted CCTP provider for Unmet, we utilized their resources. We utilized the care coordinator in the medical home. And so it was just a very, very good example. One of the other things is that as we are delivering these services, they're very short-term and very focused and targeted. Yet, especially even like Heather's background with care management, when we get into the home, our eyes are looking at everything. And so the other nice option with this, which I think reinforces the ability for us to have a significant impact on those hospital readmission reduction rates, is that if something comes to light where we feel that they might benefit from some ongoing services, we're able to make those referrals back into some of the programs here at ENOA. Let's see here. Some of our programs that we have been able to utilize is our care management services, where a care manager can go in and complete a comprehensive assessment, especially, say, for some of these participants that we find that have very little informal supports. There may be some resources out in the community that we can connect them with, and so they're a referral for some ongoing follow-up to make sure that those resources are put in place is a good hookup in our care management services. This year, ENOA was able to expand their caregiver support program. It's been very, very successful. And in that particular program, we look and actually developed a very comprehensive assessment that focuses on the caregiver and the caregiving experience and what that caregiver expectations are. It's been very enlightening for our staff here in some of our participants who had been involved previously in our caregiver support program prior to using this tool. As we went through this past year and did that assessment, it's amazing how some of those caregivers really don't see their role as unique. They see it as, this is what is expected, this is what I should be doing. And we have been able to put a lot of respite services in place this year to really assist those caregivers in sometimes taking care of their own health care needs, and just to give them a break, to help them focus a little bit more on themselves, to decrease their stress levels, and hopefully helping them to maintain that caregiver role. We also can utilize our nutrition services. We have a registered dietitian that goes out and does our assessments for us. Through those consultations, if needed, we also have a nutritional supplemental program where we have Ensure available and those types of items. Our home delivered meals, as we've seen in that last example, are something that are very valuable to clients, especially when they're getting out of the hospital. And maybe they just need home-delivered meals for a short period of time, and that's something that ENOA can accommodate. I know in other situations, Heather has utilized our durable medical equipment program. This is a program in which ENOA is able to purchase for clients certain pieces of durable medical equipment that are those that are usually not covered under Medicaid or Medicare, and so that has been helpful. ENOA also has a personal emergency response system program. We have 2 providers there that we utilize, and on this particular program, we're able to do that as a reduced rate of the cost. We do ask, as we do for most of our programs, everything is based on a contribution rate, but ENOA never declines providing services to participants based on their ability or inability to make those contributions. Then we also have personal care programs, which include our bath aid and homemaker, and then we also have a chore service which does some limited lawn care and snow removal, as well as our aged and disabled waiver program. And that program really is doing home and community-based services for those age 65 and older who are Medicaid eligible and meet nursing facility level of care. Here just recently, we were notified, I think it's been about 10.5 years since we've seen an increase in our allotted budgets to provide in-home services, and we received a significant increase which will allow us to be able to provide more services for those frail elderly in alternative placements outside of a nursing home. And then also we utilize our volunteer programs. We have a lot of volunteers who are willing to go in and tackle some of those jobs that most people wouldn't, such as going into a very disarray home and doing that first initial cleanup and organizing, which sometimes requires, as we term it, a pick crew, where we have the dumpster pulled up alongside the house, and it's a basic complete overhaul. And so our volunteers have been very instrumental in doing that. We also have other programs that we can utilize that can help decrease some of the isolation for seniors, where we have our Senior Companions program, which we actually utilize senior volunteers who get a small stipend, and they go out and visit other seniors in their home. They're also, depending on the volunteer's choice, able to do some transportation, perhaps take that senior out to lunch. They are also able to do some very light housekeeping for seniors as well. But truly the most beneficial part of our Senior Companions program is the socialization part of it. I just wanted to let folks know that if you'd like more information or have potential referrals or questions, you can always contact the Eastern Nebraska Office on Aging and ask for our information and referral staff. And so here is our contact information. And with that, we would be open to any questions?
This is Jennifer again. Oh, Heather, thank you for sharing those stories with us. I think at least all of us here at Summer around the table were very engaged during that and could just imagine all the work that you did with those folks to help them. Appreciate the detail that you gave on that, and we certainly know that there's many, many more out there that could use these services. And Janelle, thank you so much for your presentation. I think that we have a couple questions here at Semro, and I'll let Paula ask hers, and then after we finish, we'll open, or actually, I'm going to keep the lines muted. If you have a question, go ahead and press *6, and then you can state your question. But first, I'll hand it off to Paula to ask hers.
Hi, this is Paula. I was just wondering how your coaching program has impacted the hospital readmissions.
Janelle, if you've muted your line, you need to do *6.
Can you hear us now?
Yes.
Okay, perfect. UNINET business, the tracking of those numbers, I think the readmission, because we join forces with them, so they also have discharge transition folks that do a lot of phone follow-up as well. They have seen significant reductions in the numbers, but I don't think that we've ever segregated out the actual participants that ENOA has worked with.
Okay.
So this other woman, is coaching available other than through the UNINET network? Is this available to individuals, or is this available through other hospital systems, or is there something we could do that might make it more available? Do you have capacity to coach more people? That was a long question, I'm sorry.
No, that's okay, and I'm glad that you brought that up. That's actually in part why we're expanding our staff at this point, is that ENOA, we're preparing for our next fiscal year, and so our hope is to engage and to market our services into different hospital locations here in the Omaha metro area, because it is going to be available. We really, and now that we've been able to experience it, feel that it's extremely valuable, and it's the beginning, and that's kind of what we tried to bring out in this presentation. It's really the beginning of a whole new world of collaboration, I think, between, again, agencies like ENOA with the healthcare setting providers.
And so I think the answer is no, it's not available outside of the UNINET right now, but it soon will be?
Correct.
Okay. And is this the service that you envision will just be a relationship between Eastern Nebraska Office on Aging and the hospital systems, or between Eastern Nebraska? I mean, or is this something I could buy for my mother when she gets sent home from the hospital?
I guess we haven't really looked at it in the private individual market. We've been looking at the hospital settings and perhaps healthcare, the insurance providers, but we really didn't look at it on that individual private market yet.
Okay, and then if you have a relationship with Uninet, and right now you're coaching Uninet people, what's happening if people go home to not Omaha? What's your radius out of Omaha that you provide this service?
Currently, we are actually over in Pottawatomie County as well when we started our contract over there, because that kind of crosses our line. So we're outside of what we would say ENOA's lines are, because we typically service the 5-county area, which would be Dodge, Douglas, Sarpy, Washington, and Cass County. But we have been out into, like I said, the Pottawatomie county area, and we have gone into the Saunders County area. At this point in time, what we have done, just for travel and time-wise, we really look at the referral to see the need. And so I know we've been to Saunders. Have we been anywhere else outside of ours? Yeah. So typically we'll do the 5 counties, and then, like I said, we kind of look case by case if it's in the Saunders County area or some of those outlying areas, because they're there, yeah.
Is there any possibility, so there's not a whole lot of possibility for Eastern Nebraska to spread this across the state, right? Would it be other area offices on aging that would spread this across the state?
I think that, yeah, that typically would probably be most likely because we do have a total of 8 area agencies in Nebraska that do cover the entire state of Nebraska. And so primarily most of our services are designed through the Older American Act funding to our designated geographic locations.
Okay. Thank you.
Thank you.
And this is Jennifer. I have a question just to look at some of the other programs, not the coaching program that you have, but some of those others that you listed, your volunteer programs and that. Does someone, if they have, a relative that they think could benefit from this, or they have a patient, they just call your referral line? Is that how that works for those other programs?
Yes, we have a generalized information and assistance staff that take all of our referrals, and then they will filter it to the most appropriate program. Some of our services that we offer, such as the personal cares, those come through our care management program. So typically if people are looking for those types of services, that referral will come straight to care management, and that's how you access those services. But home-delivered meals is a service that is on its own, and then like our senior volunteer programs, they are independent services that individual referrals can go to.
Great, thank you. Does anyone out there that's been one of our attendees, do you have a question? You can press *6. Well, if we don't have any other questions, I want to thank everyone for attending. This session has been recorded and will be posted to the Summer of Nebraska website. That posting usually takes a week or so. So if there are people that you know that would benefit from having this information, please, you can forward on the information that it will be on the website here in a week or so. Also, after the conference here today, I'll send out an email. If you please do our SurveyMonkey for the evaluation, that'd be great. And you can email or fax in your sign-in sheet. I want to thank everyone for attending today, and if there aren't any other questions, we'll let you go. Thank you. Thanks, Danelle. Thanks, Heather.
Thank you.
Thanks, Jen.